Good afternoon, everybody. I've just finished an interview with CBC, the Canadian Broadcasting Corporation, and they wanted to talk about Lyme disease in Canada. And we had a good chat, and probably 20-minute chat, which will be aired on a CBC podcast in the fall. But I was struck by one of the issues that arises very often in my practice when I'm asked to treat complex multi-symptom patients who often will come in and say, I've got Lyme disease, can you help? I've seen 5 doctors, naturopaths, etc., but I'm no better. And one of the biggest frustrations has been people believing that there's one single trigger for their presentation, and having 1 or 2 positive antibodies on a lab test, which to them indicates, or which they've been told is a positive Lyme marker, and they should be on a full treatment program. So I think this is it's medical malpractice actually to jump into the diagnosis and treatment of Lyme disease without a considered approach. And we do know that there are 2 schools of thought in the whole standard of Lyme diagnosis. There's the traditional infectious disease specialists who have a very strict criteria for the diagnosis of Lyme disease, rightfully or wrongfully. And then there's a more broadened approach to the diagnosis of Lyme disease and the understanding of Lyme disease and treatment, which is purported and put forward by a group called ILADS, to which I happen to belong. And between the 2, they don't see eye to eye, and there's continual friction, of which the patient sits in the middle trying to work out what's really going on. They may get a diagnosis of Lyme disease from somebody they've seen based on a US test, then get sent by their family doctor to an infectious disease specialist who then reads them the riot act and lets them know that the tests are recording too many false positives, that they're irrelevant, and that the lab's just trying to make money and the labs aren't standardized. And this battle goes back and forth, and the poor patient sits in the middle trying to make sense of it all. And at some stage, I aim to do a talk on the differences between the 2 approaches and the specifics as to why one group is vehemently sort of certain of their position and why the other group contests that position and has their own set of criteria for diagnosing and treating, which, if you look at the data, can't be invalidated. It has to be taken into account as well. So, as I said, the patient gets in the middle of this and doesn't know which way to turn, and it's frustrating for everybody. So here's my take, just a small take-home take on patients who believe Lyme may be a trigger. Without a thorough history, Lyme disease and the co-infections are based on a very thorough clinical history. Again, I'm not going to go into the specifics of that clinical history. But the doctor interviewing you or the healthcare professional interviewing you must spend a lot of time taking a very specific history as to what symptoms you're presenting with and how you came to this diagnosis. Just to come in and walk in with a positive lab test, whether it be US-based or even Canadian-based, is not a good enough. Although the Canadian test, if it's positive, there's a very strong likelihood that Lyme disease is playing a role. The Canadian test has these very strict criteria for making false positives and false negatives. And if you have a positive test in the Canadian lab, it's very likely that Lyme is an issue. So I suggest that your practitioner takes a very thorough history and starts to use certain criteria in order to make the diagnosis. One is there a history of a visit to an endemic area Secondly, is there a history of tick bites? Thirdly, is there a history of rashes? Now, the problem is many times, in fact, not most times, there isn't that history. But if the history is there, that guides you in a certain direction. And you have to ask those questions. Then they have to take a full list of symptoms in order to try and differentiate whether your symptoms are specific to Lyme and the co-infections, or whether they cross over with other conflicting or added um, potential causes for illness. For instance, we know that Lyme disease patients, the disease is characterized, particularly in the later stages. The earlier stage is a whole different story. The first 30 days, that's a different saga. But in the later stages, it's characterized by migratory polyarthritis, so joint pain or muscle pain that goes from joint to joint or muscle to muscle. These sort of symptoms are very diagnostic. There are other things that do it, but in the context of exposure to tick-borne illness, if those symptoms exist, you want to dig deeper. So migratory polyarthritis or muscle pain, that's a very big symptom for Lyme disease. Now the co-infections, the Babesia, you want to ask very specific things. Do you have night sweats? Do you have day sweats? These are very specific for Babesia symptomatology. Do you have shortness of breath or air hunger? Do your symptoms come and go? Are there a lot of emotionally based symptoms, particularly anxiety associated with Babesia? You want to ask these very specific things. For Bartonella tends to be more peripheral, so you tend to get a lot of pain syndromes, more neuritis, you get pain in your peripheral nerves. You get painful soles of the feet, particularly when you get out of bed in the morning. So the history is all important, and Lyme disease is now considered to be a clinical diagnosis based on history and physical examination. It is not based on a positive lab test, because you do get false positives. And depending on which tests you run, the interpretation of which is highly complex. Unfortunately, due to cost, we have a few tests. We have the Canadian tests, which are elementary and introductory at best, although the infectious disease specialists will say that they are good enough. I do disagree with that. When you want to look further and beyond, you do have to look at more advanced testing, but it's cost prohibitive. Most people can't afford what's really needed. I do try and get as many tests as I can across the spectrum of different testing types, whether they be what they call B-cell antibody testing or T-cell testing, PCR testing, plasma testing, fish testing. The more tests you can get, the more that you correlate those tests with the clinical diagnosis and the symptom profile picture, the more you can sort of hone in on the diagnosis of potential Lyme disease, which is rising in Canada at a very alarming rate due to the migration of ticks and songbirds north. Interesting statistics is that there was a study done showing that South American ticks, the 32 million ticks are brought north by South American birds every year. That's pretty alarming. And the songbirds that we know are migrating further north due to global warming and spreading their tick-borne load further and further north, hence the rise in tick-borne illness in Canada. So be cautious. Do not jump to a diagnosis of Lyme disease because you have a positive test. Make sure that you have a very thorough history taken. Make sure that the person who's interviewing you has experience in the diagnosis and has experience interpreting lab data. The more lab data you can do, the better. Do not rush ahead and treat yourself for Lyme disease without due caution. It can lead you into the wrong direction and make your immune system and your gut microbiome quite compromised if you treat inappropriately with some of the drugs out there that are available. Just a word of caution. And this was covered in that podcast, which should be aired at some stage. Thank you.